Module 4 focuses on the use of medication for addiction treatment, or MAT, for opioid use disorder. Beginning with a description of how these medications work. Details are then provided about the efficacy of available medications, for example, methadone, buprenorphine, the combination of buprenorphine, naloxone, and naltrexone. The rewarding aspects of opioids come through activation of the mu-opioid receptor, and the mu-opioid receptor in these reward areas of the brain, their intrinsic activity, which is what's shown on the graph on the right side of this slide. What happens with a full agonist at the top is that it binds and fully activates the receptor. Now, if a full agonist is relatively short-acting and has a very rapid onset, that will give the feeling of the rush, the high, the euphoria, and those typically are the most abused substances. However, if you give something that's very long-acting and it's a very slow onset, but occupies that receptor in a competitive way against the short-acting, that will build tolerance. And so the person, in order to achieve the euphoria, will need to have a very high dose of a short-acting agonist. And that's sort of how methadone works, is it occupies the receptor, it competes against the short-acting agonist over a very long period of time. It also negates the negative reinforcing effects, so it reduces the withdrawal that folks experience. At the other end of the spectrum are the antagonists. So an antagonist at the bottom binds the receptor but does not activate it. So that's illustrated by this straight line at the very bottom of the graphic. The example of that is naltrexone. So naltrexone, you get no pain relieving effect from it. You get no feeling of being normal or from it. It has absolutely no abuse potential because there's no way to get any euphoria from it. And so typically when it was introduced orally, patients wouldn't take it because there was nothing reinforcing the medication taking behavior. This is the reason why now it's used in a monthly injectable form to be sure that folks are adhering to the medication. And sort of in between, in the middle of this slide, are the partial agonists that binds and activates to a ceiling. And that's what buprenorphine is. You'll see at the lower end of the drug dose on the left, it acts very similarly to the full agonist, right? There is an increase in intrinsic receptor activity. So there is a little bit of a positive feeling that folks get. But it's not so much that they're feeling high. It's enough that they're feeling normal, that it's relieving the withdrawal symptoms. But then it hits a ceiling. And once it hits that ceiling, there's no more increase of intrinsic activity. And that's what makes it safer. So there's less risk of respiratory depression, less risk of misuse. So that is how the three medications tend to work. The medication treatment of opioid use disorder, there have been decades of very well done randomized trials showing that they're effective in reducing relapse, overdose, infections, and other harms. As we mentioned, the three options are agonist therapy with methadone, partial agonist with buprenorphine, and antagonist with naltrexone. And the thing to bear in mind is all of these medications have been studied in the context of other counseling. So clearly to do that, a team approach is best to address those co-occurring medical and psychiatric and social issues that our patients experience.
Dr. Friedmann, I just want to add that we found in our health center that patients don't usually stay on injectable naltrexone. We've received some patients coming from prison who received it there, but once they've had their first injection with us, they don't tend to stay on it and tend to transition over to buprenorphine. I've also found that it's very difficult to start in an outpatient setting because it could throw patients into withdrawal. Patients need to be off of all substances, off of all opiates for at least 7 days, and when transitioning from methadone, even longer. So the startup is incredibly difficult. They would need to take oral naltrexone first to make sure they're safe, and then transition to injectable. It's very challenging.
Yeah, I think the experience with naltrexone bears that out. However, it is a useful tool, and there are people who want that approach. And I view all of these as, the things we have in our, some people say tool belt. I like to say my bat utility belt. This notion that one medication is going to work for everybody is a fallacy. Clearly, there are many different roads to recovery, and there are many different ways the medication can be used. Methadone has to be done in a very highly structured, supervised setting for folks who need that kind of support, for folks who need more agonist activity in order to overcome the craving. Methadone, is an important option that really needs to be available to folks. Buprenorphine is safer. It can be used in the office setting with, less restrictions than methadone. It allows the patient some flexibility. And so that's a good option, for patients who have a relatively good prognosis. And then naltrexone is useful for folks who really want to seek to avoid opioids. It's just given once monthly. And it's also useful as if somebody's deciding to taper, for example, off some of the others during that period where they're first off of everything. It's sometimes a useful tool to help in that transition. The medications have their pluses and minuses. The methadone is highly stigmatized. People don't want to go to the programs. There's a lot of daily dosing, particularly at the beginning of treatment. So it's really very restrictive. And some people need that structure. There can be issues with QTC prolongation and drug interactions. Buprenorphine has fewer of those issues because it's given in the office. It has to be given daily. There are more issues with diversion with buprenorphine. And of course, providers need to complete a training in order to get a waiver to do it. And naltrexone, as Dr. Gaberman mentioned, you really need to be opioid free. It's difficult to do an outpatient induction onto it. Dr. Gaberman also mentioned the risk of overdose if folks stop it and resume use. And again, the issues around pain are challenging. The thing to bear in mind, though, is even given all of these challenges, it's still far superior to the medication-free treatments that we see. So a huge effect size has been seen for medication versus tapering. There was a very well-cited study from 2003 in the Lancet that compared a buprenorphine maintenance protocol to a 6-day taper. And what we see in this graphic is that the very few folks remained in treatment after the buprenorphine was stopped. The thing that it was not powered for was a small study, only 20 patients. They received sort of state-of-the-art Cadillac counseling, 20 patients in each arm. There were no deaths in the maintained patients and 4 deaths in the detox patients, which reached statistical significance. So that suggests that really it's a huge, huge effect size. This has been borne out in many studies. This is not a simple thing like, getting a 2 or 3% percentage point reduction in MI like you get with statins. This is really a huge life-saving treatment that we see, and it's been consistently shown. The other thing that's been shown is that, this is a chronic disease that's relapsing and recurring, but the number of relapses in treatment studied by Robin Clark at UMass, it shows that those who get non-medication treatment have many, many more relapses than those who are over the course of treatment than those who are treated with medication. And the thing to bear in mind in this day and age is that every time somebody relapses, they're at risk to die, right? Because the illicit supply on the street is really risky, and there's a lot of fentanyl out there. So relapse, does occur in these folks, and And Dr. Gaberman, can you tell us a little bit about your experience with relapse for folks who've been on medication?
Well, as we spoke about, opiate use disorder or all substance use disorders are chronic medical condition. So though medication treatment helps people enter into remission, there are still episodes of relapse. Patients may also still struggle with other substance use, such as cocaine, in the case that I relayed to you earlier. But when you're working with patients who are in a medication addiction treatment program, it's important to use behavioral contingencies because contingency management can be helpful. And in fact, with the cocaine, where there isn't a medication to treat cocaine use disorder, oftentimes that's the only thing we have to offer. So when patients are doing well and are in remission and remaining off of opiate, we oftentimes will extend their prescription for medications such as buprenorphine to 28 days, which allows them much more flexibility so that they can go on with their life and live the life that they value and do the things they want. When patients are struggling and having episodes of relapse, we shorten the interval of the prescription, as I mentioned earlier, to 7 days. Some programs do it even to twice a week. We're not able to do that. And again, the plan has to make sense for the patient, but also for you and your office. And it depends on what you can accommodate. But when patients relapse, we try to see them every week. We increase the amount of urine toxicology screening we do. And we really push for them to keep their counseling visits and to work with a counselor closely. If their relapse continues and they don't respond to this, then we start talking to them about a higher level of care. I will always bring up methadone maintenance with patients, and a lot of patients are very resistant to that. And I don't push them if it's something that they won't do, but it does offer more structure. And some patients find they do better going on methadone maintenance. We also offer people referrals to intensive outpatient programs or partial hospitalization.
Yeah, these are often challenging patients. The cocaine issue is often difficult, and I also use these same approaches that you really want to intensify treatment. I think you want to emphasize to the patient that this is not a punishment, but really this is to try to get them back on track and help them develop some skills to be able to deal with some of the temptations that are out there.
Mm-hmm. I agree.
Great. So, for some of these folks, some of these who've relapsed, some of these longer term medications might be useful. Those who are either struggling with recurrent use or whom you might be concerned about diversion. Folks who use cocaine, I'm always concerned about diversion. I'm always concerned that folks are selling part of their bupe dose or bartering to buy cocaine. And some of those folks might be appropriate for some of the injectables. So we've talked a little bit about the monthly injectable naltrexone and a number of studies that have shown, as we've mentioned, they have to be completely opioid free. It's very challenging for the induction. Often they need to be in an inpatient detox or incarcerated in a completely drug-free setting before they're able to do this. There are some outpatient protocols that use increasing doses of oral naltrexone to get folks started. I've not used any of those. Have you used any of those oral protocols, Dr. Gaberman?
I haven't, and I also just want to just say that I approach cocaine, and I think our concern also is diversion. But on the other hand, I think we need to step back and look at the graphs, the studies you just presented, and how important it is to treat patients with these medications for their opiate use. And oftentimes these are, I think they need to be addressed separately, quite honestly. And I haven't found naltrexone helpful. And I think that patients at greater risk, the greatest risk for overdose are often the people that are polysubstance users. So pushing those patients onto naltrexone, where I think they're going to lose their tolerance and have a higher risk of overdose, I would be very concerned about.
this sort of bears out what we've been talking about. Once folks are able to get onto the medication, they do as well as folks on buprenorphine. But really the challenge in this, on the left side of this graphic, the intent to treat population, the challenge is that a lot of people are not successful in sort of in getting into the opioid-free state that allows them to get onto the medication. But once they do, they tend to do pretty well. In terms of opioid craving, what the study also showed, comparing extended release naltrexone to buprenorphine, demonstrated is that amongst those that are on the medication, there is less craving, slightly less but significant decrease in craving early in treatment amongst those that are on extended release naltrexone. Those effects tend to fade over 24 weeks. The thinking may have to do with sort of what's happening at the level of the opioid receptor. But in point of fact, this is in the per protocol, not the intention to treat. So this is amongst the people who've received the treatment. And again, it doesn't negate the challenges of getting folks on the treatment. And one of the tools I think many of us are very excited about is the monthly injectable. So monthly injectable buprenorphine, which has been recently marketed. And that's going to be a useful tool, again, for folks that we think are having trouble with adherence to daily medication. Those folks might do better coming in for a monthly injection. But the overall message is that agonist treatment saves lives. This graph shows two studies that have dramatically shown this. The one on the left is from Baltimore. During the period where most of the rest of the country saw an increase in overdoses, Baltimore saw a decrease in overdose over the 2000s, largely because of a very aggressive program of increasing access to primarily buprenorphine, but there was also a more gradual increase in methadone. Similarly, in France, when they undertook a program of aggressive use of buprenorphine in primary care settings for opioid use disorder, they saw a change from an increasing amount of overdoses on the left. This is on the right-hand graph. On the left-hand side of that graph, you see that there were increases in overdose deaths, and then once they implemented an aggressive buprenorphine program in primary care, there was a dramatic drop in life-saving effects. So medication for opioid use disorder saves lives, but it's not often prescribed. Recently, Mark LaRochelle from Boston Medical Center published in the Annals of Internal Medicine an impressive study using retrospective data from Massachusetts, over 17,000 individuals who survived overdose, and looked at what happened to them. Only 30% of them received medication. The highest risk for death after an overdose from overdose is having had a prior overdose. What they saw was that individuals' all-cause mortality was greatly reduced by methadone and buprenorphine, and they did not detect an effect of naltrexone. Again, bearing out that we really need to do more to get medication out there. The Surgeon General's reports the science is really clear. MAT works. The Surgeon General says the use of opioid agonist medication to treat opioid use disorders has always had its critics. You know, this slide, and it's sort of a long statement. This is, it's not substituting one substance for another. The abstinence-only philosophy, or the medication-free philosophy, as I prefer it, really is detrimental to people's lives, and I think is a large cause of a lot of the deaths that we're seeing. And we have decades of research that show that the benefits of medication outweigh its risks. So in summary, medication treatment extinguishes the out-of-control drug-using behavior. Remember, we said it blocks those receptors and competes against the short-acting, and in doing so, reduces the drug-using behavior, the consequences, and craving. We have three types of available medications. They're all efficacious. But as of now, only methadone and buprenorphine have been demonstrated to be life-saving, and really those should be first line.